Hi, and good afternoon. Welcome to Congressional Black Caucus Foundation's Policy for the People series, a six-part virtual brain trust providing critical updates on the most pressing issues facing the Black community in the United States in the era of COVID-19. I'm your host, Dr. Mena Demise, Vice President of the Center for Policy Analysis and Research and the Leadership Institute, and your moderator for this afternoon's panel discussion entitled Black America, the Double Pandemic, sponsored by Johnson & Johnson. We want to thank Johnson & Johnson for their support of the CBCF and leadership on tackling health disparities, particularly for the Black community. You will also get a chance to hear more about J&J's work and leadership in this space from their Executive Vice President, Global Corporate Affairs and Chief Communications Officer, Will Sneed. But before introducing our panelists and Congresswoman Robin Kelly, strongest advocates and policymakers advancing health equity in the United States, as well as our other distinguished panelists, let me share with you that if you are joining us for the first time, we encourage you to watch our past 4 series on our homepage at www.cbcfinc.org, where you also can learn about our upcoming annual legislative conference, how to support the foundation with our internships and scholarships for the next generation of leaders, as well as our recent launch of CBCF's National Racial Equity Initiative for Social Justice in order to effectively combat racism and discrimination in everything from law enforcement to the courts, classroom, and workplace. We will also be providing social justice scholarships for students at HBCUs, as well as offering social justice policy fellowships for young leaders who want to make a difference on Capitol Hill and across the country. Since April, the CBCF has brought experts, thought leaders, and members of the Congressional Black Caucus to provide insight and analysis every 2 weeks for the past few months. We focused on the impact of census turnout for the Black community with Congressman Stephen Horsford. We've focused on the economic stimulus package with Congresswoman Terry Sewell and the importance of understanding how to access federal, state, and local resources to financially sustain the global pandemic. And we've also talked about water governance and the water workforce with Majority Whip Jim Clyburn, and as well as talking about digital equity as a tool of access for the Black community with Committee Chair Congresswoman Eddie Bernice Johnson, Congresswoman Barbara Lee, and Congressman G.K. Butterfield. So it is in this vein that we arrive at today's discussion, focusing explicitly on the double pandemic for Black America as we wrestle through racial health disparities and gain a deeper understanding of the problems, but also the immediate and long-term solutions. And it is in the spirit of unapologetic mobilization for positive change in leadership that I'd like to introduce to you Congresswoman Robin Kelly, who is a member of the House Committee on Energy and Commerce and the House on Oversight and Reform. She is a stalwart leader on public health access and equity. Many of you might be familiar with her Kelly report from 2015, which was a comprehensive report with policy recommendations and initiatives for policymakers and healthcare professionals and practitioners on the front lines of health equity for a healthier future for all. She's led 12 teleconferences with regional elected officials, educators, hospital CEOs, and young frontline workers to answer questions and share information. She's been on the front lines in getting resources for her community in Chicago, but also across the country, gaining about 11.3 million. She recently made an announcement of funds awarded to 5 community health centers on Chicago's South Side and in the South suburbs. She is a strong advocate for the collections and releasing of demographic data, including race and ethnicity as it relates to COVID-19. So without further ado, I want to turn it over to our distinguished advocate, literally on the front line, health equity. Please take it away, Congresswoman Robin Kelly.
Well, thank you so very much for inviting me, and good afternoon, everyone. Thank you to the CBCF for holding this very, very important conversation. As you said, the 5th in a series of 6 examining the impact of COVID-19 on the African American community. However, unlike many calls, CBCF policy calls go one step further. In addition to examining the project, CBCF connects members of Congress to enact real, life-changing legislation that uplifts our families and our communities. Today's call is entitled A Double Pandemic. While tragic, I can't think of a more fitting title for this conversation because with COVID-19, our nation is seeing 2 pandemics, one in wealthier, whiter communities, and one in more vulnerable communities of color. This is America, and we are all Americans. There shouldn't be a two-tiered system, but generations of health disparity, inequities, and a lack of access to care have created two Americas. Even before COVID-19, we lived in a nation where the zip code in which you were born determined how long and how well you would live. COVID is just the latest in a series of health threats, from diabetes and maternal mortality to asthma and HIV, that have had a disproportionate impact on our community because we've lacked basic healthcare services for far too long. By now, we've all read the shocking, but actually not surprising statistics showing that our family members are dying more from COVID-19. So I want to focus on where we go from here. How do we tackle these insidious health disparities that continue to force Black and Brown Americans to live shorter and less healthier lives? In 2015, as was said, I released the Keller Report on health disparities. Naomi, can you put the link into the chat and on the screen, please? This report is the first congressional examination of this issue. It also makes a series of policy recommendations to start reducing and eventually eliminate these disparities. I would encourage you to read the report, especially the recommendations page. Since that report 5 years ago, I've been working to turn these recommendations into policy, and I'm glad to report that I've actually had some success in this environment. One is expanding dental care access. My Action for Dental Care Health Act passed through a Republican-controlled Congress and was signed into law. This bill will, in a few short weeks, start putting dental health resources into the fields to help people stay healthy. I was able to work with Congressman Mike Simpson, a Republican dentist from Idaho, to enact this bill. We've also fought hard and soul, along many of you, to protect the ACA. And our nation's opioid crisis has pushed Congress to enact substance abuse legislation, another Keller Report recommendation. But I know that you will be with us in the fight until it's done. Right now, Congress is working to enact more recommendations, and we really need your help. First, as part of the House Democrats' effort to lower the cost of prescription drugs, we're using the cost savings to reinvest in Medicaid and Medicare so they can deliver dental, hearing, and vision care to recipients. I'm carrying this bill, and it's HR 4650. Additionally, I've introduced a number of COVID-19 specific bills that also address health disparities, like the Community Solution to COVID-19 Act, HR 7077. This bill, introduced with Senator Cory Booker, would create a $1.5 billion grant program for local and grassroots organizations to conduct or expand health disparity elimination work. Let's face it, if we want to end health disparities, we need to invest resources in the communities suffering from them and empower those communities to build a better future together. Another measure, HR 7078, would examine how telemedicine helped or hindered the delivery of care during COVID-19. From anecdotal stories I've heard that some doctors are having nearly 100% of their patients keeping their appointments because Zoom removes the need for 2 buses and finding childcare for some people. Now, before I wrap up, I want to circle back to the data for a quick minute. When this first started, the CDC refused to collect and analyze racial disparity data. We only knew about these numbers because individual states and cities had the courage to publish their numbers and say, we have a problem. Since day one, this administration's response has been inept and pitiful. When my bill, the Equitable Data Collection and Disclosure Act, was added to the 4th bill, it required the CDC to send a report to Congress. What we got was less than 3 pages and more a series of links than analysis. It was pitiful and shameful. I was embarrassed for the CDC director. From this experience, it's clear that this president and his administration does not seem to care about us, our communities, or the disproportionate impact COVID-19 is having on our families. We have since talked to the director of the CDC, and he promises more information and a much better report because we deserve better. The American people deserve better, and we need to demand this. Thank you again for letting me join. I need to hop off to return to the CBC Police Accountability Forum, but thank you so much, and never hesitate to contact my office. Thank you so much.
Thank you, Congressman Kelly. We so appreciate all the work that you're doing. Thanks for your advocacy, your leadership, and for being on the front lines as we wrestle through the latest of a series of incidents and happenings over the murder of George Floyd, and being a stalwart leader for the Congressional Black Caucus. Thank you for all that you do.
Thank you. And if people have questions, they can contact me or let me know and I'll get back with them.
Great, excellent.
Okay, thank you.
Congresswoman.
You're welcome. Bye-bye.
Great. So to our audience, as we now move to our discussion, you'll get a chance to hear from our panelists. Let me briefly introduce them to you. Next, you'll hear from Dr. Kamara Phyllis-Jones, who is the 2019-2020 Radcliffe Fellow at Harvard University and past president of the American Public Health Association. You'll also hear from Dr. Oscar Allen, Chief of Programs and Services, National Association of County, City, and Health officials. You'll hear from Levarn A. Burton, the President and Chief Executive Officer for the American Kidney Fund. And you'll hear from Michael Sneed, Executive Vice President for Global Corporate Affairs and Chief Communications Officer with Johnson & Johnson. I'd like to now turn it over to Dr. Kamara Phyllis-Jones. Many of you know her, family physician and epidemiologist whose work focuses on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. Before I turn it over to you, please know that this is being broadcast on Facebook Live. We are taking questions from your Facebook feed when we get into the discussion portion, as well as those of you who are registered with us as attendees through Zoom. You can go to your Q&A chat feed at the bottom icon and load your questions into there. So please also use our hashtag CBCFINC. That's hashtag CBCFINC or hashtag Policy for the People. Without further ado, Dr. Phyllis-Jones.
Hi, Dr. Demasay, thank you very much, and thank the CBCF for holding this series of fora. I want to spend the 5 minutes that I have been given to talk about the double pandemic, but maybe shed not only the light that Congresswoman Kelly shed on it, double pandemic, a different double experience in this country of the same pandemic because of racism, but also the double pandemic of COVID-19 and the kind of endemic pandemic, the constant generational, centuries-old pandemic of racism that we see not only in COVID-19, not only in the fact that we have, that we have more high blood pressure and our babies are dying twice as often before their first birthday than other people's babies, or our women, in childbirth dying 3 times as often. Racism as the other part. So what I want to do is just share one of the stories that I use. I do a lot of speaking on issues of race and racism, and I share allegories, stories based on something from my own real life experience to help people understand. So this story, many of you on this who are joining us now know about racism, but this story is a tool that you can talk to your neighbor or your friend or the person on Facebook with you who's like, oh, I don't know, what to do or whatever. This is the story you can tell them to help them understand that, yes, racism exists. It has existed. It still exists. It is the target that we need to dismantle. So I've already given you the moral of the story. What happened to me to bring this insight about? As a medical student, first-year medical student, very diligent, one Saturday I'm studying in my apartment and some friends come over. So then they join me in studying and we get to studying long and hard and it gets late and we get hungry and I have no food in the apartment. So my friends understood that was typical for me. So they were like, okay, Kamara, never mind. Let's go into town and find something to eat. So we go into town and we find a restaurant and we walk in and we sit down. And the menus are presented and we order our food and the food is served and there we are eating. Not a very illuminating story yet about racism. But as I sat there with my friends, I looked across the room and I noticed a sign that was a startling revelation to me about racism. So now I've intrigued you and you're like, Dr. Jones, what did the sign say? Well, what did the sign say? The sign said, open. So I know I've lost many of you. So let me recap. Here we are sitting in a restaurant eating. I look across the room. I see a sign that says open. If I hadn't thought anything more about it, I would have assumed that other hungry people could walk in, sit down, order their food, and eat. But because I knew something about the two-sided nature of those signs, I recognized that now, because of the hour, the restaurant was indeed closed, and that other hungry people just a few feet away from me, but on the other side of that sign, would not be able to come and sit down, order their food and eat. And that's when I understood how racism is structuring open-closed signs in our society. That racism is structuring, if you will, a dual reality. And for those who are inside the restaurant, sitting at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on, because it's difficult for any of us to recognize a system of inequity that privileges us. So it's difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It's difficult for all Americans to recognize our American privilege in the global context, right? Yet those on the outside are very well aware there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, then you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. Doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, which is an if, but if you do, then you could even talk to the restaurant owner, who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the restaurant? Let them come in. You will make more money. And oh, the conversations we could have. Or maybe what you'll do is pass food through the window. Or maybe you'll try to tear down that sign or break through that door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign. So I give you that story to illustrate that, yes, racism exists. It's creating, it is a two-sided or multi-sided sign that's creating a dual or multifaceted reality, the double pandemic that Congresswoman Kelly talked about. Later, I need to cede my time now, but I'd love to give you a definition of racism so somebody can ask about that, and then go deep in some other things. But thank you very much. And just to say that racism is not just the sign, it's the door, it's the lock, all of it. Thank you very much.
Thank you, Dr. Jones. Such a powerful analogy that really gives us insight into exactly what we're battling here. My friend often says racism is a national public health crisis, and sometimes people don't wrap their heads around that, but understanding that everybody has a role to play in advancing equity. It's not just Black people for Black people, right? Everybody's either on the open side or the closed side of that restaurant and can do something about it, providing that equal opportunity to all. So thank you for that powerful story. I want to turn it now to Dr. Oscar Allen, the Chief of Programs and Services for the National Association of County and City Health Officials, where he oversees a $28 million portfolio of programs. He's an epidemiologist by training and brings years of local health department experience responding to health issues, including West Nile, H1N1, Ebola, you name it, he's had a role to play. He is a subject matter expert on a number of national boards and work groups on biosurveillance, informatics, epidemiology, policy, and public health. And so without further ado, I'd like to turn it over to Dr. Allen for his remarks.
Thank you very much. And I do appreciate the opportunity to be with you in this very auspicious panel. As was mentioned, I am the Chief Program Officer for the National Association of County and City Health Officials. And we represent the 3,000 local health departments across the US, which a main vision of optimal health, building equity and security for all people in all communities. Our mission is really focusing on improving the health of those communities by strengthening and advocating for local public health. So essentially, those are the individuals who are on the front lines. Oftentimes we hear of there being a focus on healthcare. But there's a healthcare as well as the public health system, and all of them actually are intertwined. The health departments are those, the public health nurses, the epidemiologists, the community-based workers, and a whole list of preparedness coordinators who have been from the jump working very feverishly to try to address the issues of how this pandemic has been impacting our communities. And to the point that has been raised specifically around that of the double pandemic, they're also been working on these same issues as it pertains to health equity and social justice prior to this pandemic. And it has taken the impacts of this pandemic to illustrate the significant disparities that continue to exist, and things that we've been saying from previous time, whether it's the access to healthcare, the impact of pre-existing conditions, access to quality food, good places to eat. The social determinants of health has really played a significant damage on the health and safety of our communities, yet we remain resilient. And when we think about what we've seen specifically as it pertains to this COVID virus, we've seen hospitalizations negatively impacted, disproportionately impacting our communities of color. I point to the example of Georgia, where a study was done that showed in 300 cases of hospitalizations, half of them were women, 83% of them were Black, 25% of them had no underlying health conditions, but yet here they were hospitalized and disproportionately for COVID-19. When you think about not only the large urban communities that we oftentimes see, but we also have to really reflect on those small, rural, and other communities as well, especially in the rural communities where we're seeing meatpacking facilities. Oftentimes, many of those workers are also of minority populations and communities at risk. The impact that we are seeing from this particular pandemic has not only reduced childhood vaccinations, but really hopefully addressing in our aspiration how we can really talk about the roots of health and equity and build from a substrate that can really speak to truth to power and address those institutions that are generating those overall inequities. In my last closing piece before I pass it on to the next speaker, if you can bring that slide up. And I usually refer to individuals when I'm speaking about the different waves in the future of this pandemic and what we anticipate, what we will see. I point to that first purple curve as what we anticipate in this first quote unquote wave, right? The number of cases of illnesses, the impact on not only illness, but hospitalization and deaths. When that's followed by that green phase, which are those non-urgent, those non-COVID, but urgent conditions, which kind of got pushed back because of virtue of having to do things all COVID. And then the blue, the tail end of those chronic conditions, the heart disease, the hypertension, the diabetes, that have somewhat been suppressed by virtue of the fact that folks have not been able to access care or even be able to make sure that they are availing themselves of what they can do to improve their health outcomes. But that red curve is one of the most concerning for us all, because that speaks to the overall mental health, the stress, the anxiety, the economic injury. And as you can see, this is a very significant curve. But now paint that against the picture of seeing the disparity that exists and the inequity in communities of color. These numbers are by far going to be amplified beyond what you see on this curve. And it points for us for having building the framework to ensure that we can address these and truly turn this corner while we have the moment at our feet. Thank you.
Thank you, Dr. Allen. Really powerful slide. Thanks for illustrating that and being able to sort of make visible the ways in which psychic trauma and the after effects of racism are just as devastating as the illness itself, and can actually take much longer to recover from. So thank you for that. It's actually a great segue to our next speaker, Levarn A. Burton, president of the American Kidney Fund. You might be wondering, those of you who are not as familiar with the public health piece, what does the American Kidney Fund have to say about this? How does it relate directly or indirectly with battling COVID? And Levarn Burton will answer that for you. She has served as executive secretary to the U.S. Department of Health and Human Services, where she managed policy development and regulations and was advisor to the secretary of the federal government's largest domestic agency. Prior to that, she served as Deputy Assistant Secretary for Budget Policy at Health and Human Services and as Senior Analyst to the Budget Committee of the U.S. House of Representatives, advising the Committee on Funding Policy and Legislative Positions for Social Security, Medicare, Medicaid, and other health care programs. So without further ado, I'll turn it over to President Burton.
Thank you so much, Dr. DeMasi, and thanks so much to all of the other panelists for very interesting and enlightening presentations. I want to talk about how this disease, COVID-19, affects people with kidney disease, and I also want to talk about what the American Kidney Fund is doing to support those patients. As a public health charity, we've been around for almost a half century. Our mission is to prevent kidney disease, to educate people about it. And unfortunately, if they end up with kidney disease or kidney failure, we want to do everything that we can to help them deal with that and get the best possible outcomes. What's happening to kidney patients today, unfortunately, represents a perfect storm of the double, if not triple pandemic that we're talking about today. Kidney disease has a devastating impact on people's lives. In its final stages, called end-stage renal disease or kidney failure, it takes away a person's health and their livelihood. And most immediately, it also, if you're African American, you're more than 3 times likely to get kidney failure as other Americans. So let me start just by talking about kidney disease even before you get to COVID. About 80% of people who are on dialysis are unable to work, so they've lost their livelihood. They're already having a tremendous struggle just trying to survive and get the health care that they need. Add COVID-19, where people are told to social distance. Social distancing means a choice, if you're on dialysis, of going to dialysis and getting the care you need or not going. And if you don't go to dialysis, you die. So it is not a choice to social distance that people can make. So to get there, they can no longer do public transportation. Additionally, people who are in kidney failure, whether on dialysis or with transplants, have a very restricted diet that's more costly. They're told to social distance so they can't go to the grocery store. They have to have their groceries delivered. That's another expense that's added on to an already fragile economic existence. At the American Kidney Fund, we've been dealing with these patients long enough that we knew from the beginning how COVID would affect them. We immediately established the Coronavirus Emergency Fund. With that fund, we have thus far raised about $2.5 million and provided some level of financial assistance to about 10,000 patients. But we don't have enough to meet all of those needs, so we're still raising from individuals, from corporations, from foundations. We've also taken savings that we have from not being able to travel, and we're giving it to patients. In addition to that, we're absorbing the full cost. 100% of all the contributions that are made will go to patients. So that we know that these funds, patients are using these monies to buy food, they're using them for transportation, they're using them for medication. But we need to step back. While we're providing assistance in this emergency, this is not a new problem. With or without COVID, it continues. COVID just makes it worse. The truth is that this pandemic is shining a laser focus on the health disparities of the Black community. We hope that one positive outcome of this will be genuine changes in the healthcare system. We need to focus more on education and on prevention before people are in kidney failure. The truth of the matter is that in this country, we only assure that people can get comprehensive health care when they're already in kidney failure. We don't devote the resources to help prevent them from getting there. And we need to change that. We need to have community level intense programs dealing with chronic diseases to help people avoid chronic diseases like kidney disease or help them better deal with them to get the best outcomes. And we have scientific proof. For example, the Indian Health Service has community level programs, and they've made a tremendous difference for people with diabetes and with high blood pressure, the 2 leading causes of kidney disease. The American Kidney Fund runs the largest screening program in the country. Of course, we're not out screening right now because of social distancing. We've taken all of our programs online, and we're finding other ways to reach people who may not have access to the web. We want to work with community groups. We have lots of information through our Know Your Kidneys program, through our Kidney Coach program. We not only want to share that information with community groups, but we will teach you how to use it with your various groups so that you can get information to people to help them avoid kidney disease wherever possible, or to get the best outcomes and to manage the disease if they had it. We welcome you to join us, to partner with us, because we really want to tackle the problem that we have been working on for half a century. We're all about trying to prevent these disparities because that's the only way we're going to achieve our mission of preventing kidney disease. So thank you.
Thank you, President Burton, for shedding light on the compounding and confounding effects of the social determinants of health and disproportionate rates of public health scares that our community are facing. We'll return later, as I'm sure a lot will have folks will have questions on what the American Kidney Fund is doing specifically for our communities battling kidney disease, as well as trying to avoid the COVID-19 pandemic. So now we will finish with our last speaker and then engage in a discussion and take questions from there. Again, I want to introduce to you Michael Sneed, Executive Vice President, Global Corporate Affairs and Chief Communications Officer, and a member of the Executive Committee at Johnson & Johnson. Again, thank you to Johnson & Johnson for sponsoring this session's discussion, but also for being a longtime supporter of the CBCF on the many initiatives that we've carried out in the healthcare space as it relates to the Black community. Since 2012, he has been leading the corporation's global marketing, communications, design, and philanthropy functions. Prior to that, he was the company group chairman for Johnson & Johnson and a member of Medical Devices and Diagnostics Group Operating Committee. He has a lot to say on this topic, and I'd like to turn it over now to Mr. Sneed. You're on mute. Mm-hmm. Mr. Sneed, there you go.
Well, thank you, Dr. DeMessi. Appreciate the introduction, and thank you to all the panelists, all with very powerful stories in terms of what this particular pandemic has done to the Black community, but also, as many of you have spoken about, the ongoing pandemic of racism in this country, and now we see both of them coming together. You know, I have a personal passion in this space. I grew up on the south side of Chicago. Family of a number of healthcare physicians and providers in my family, with a long history. And so coming to Johnson & Johnson many years ago, I knew that this was also a company that was along for the journey and for the fight when it comes to really changing the trajectory of health for all citizens, not only in this country, but around the world. And that really starts at J&J, starts with our credo, where we talk about many things, but one of the things that we're very passionate about is that we are compelled to have responsibility for our communities. And this is where you see the actions that we've taken, not just today or yesterday, but as Dr. DeMessi has said, from decades of really supporting the African American community in partnership with the CBC and the CBC Foundation, and so many other groups that are critical to advancing the health of African Americans. A couple of things I want to talk about specifically with regard to Johnson & Johnson and what we're doing. As many of you may have heard, we are on the front lines of actually developing a vaccine for COVID-19. We're really, this is something that we jumped in with both feet. And again, it's not because we thought, oh, let's do this because it's the flavor of the month. But in fact, we've been on a journey around vaccinations for many years. And with Dr. Allen, as you heard about his background, Johnson & Johnson has been on the forefront when it comes to developing vaccines for Ebola, for HIV, and other challenges that disproportionately impact the African American community here, but also around the world. And so we're very hopeful that we can bring a vaccine to this particular issue as quickly as possible. In fact, just yesterday, we announced that we're able to move forward the clinical testing of our vaccine candidate from September to mid-July. We're very, very, very pleased with that, as well as the announcement that we made a couple of months ago that when we get a vaccine, and we really do believe it's when, we're bringing it to market at a non-for-profit price. So we want to make sure that as many people as absolutely possible can have access to a vaccine, because that's where we believe we can have the greatest impact on communities of color and making sure that people are vaccinated. But beyond that, which is an important thing because J&J is involved in healthcare, it's as much about the development as medicines as it is about making sure that we have those personal connections to community leaders in the communities of color. So it is about things like advancing the notion of having diversity in clinical trials, which we're very committed to. It's making sure that we can fund and support people of color who want to go into medicine and the health field because they understand on a very personal level what it's like to work in these communities and to make sure that they want to be able to give back. And Johnson & Johnson is very much committed to that. And then finally, as it relates to the situation at hand with regard to keeping our citizens safe, our people of color in these communities, from our perspective, it is about making sure that we listen to the CDC and the local health commissioners in terms of doing all the things that we all need to do in terms of washing our hands and wearing masks, and recognizing that in some cases that's very difficult in the situations in which so many of our people find themselves. But nevertheless, it's making sure that we're listening to the experts, focusing on the science, making sure that we're moving as quickly as possible, and then getting the information out, making sure we can educate as many people as possible. And we believe that's going to be the best way we can keep our community safe. And then when that vaccine comes, working with federally qualified health centers to make sure that we get access to them and that they understand the importance of vaccinations, and also to start to demystify and maybe take away some of the myths around vaccines so that our people can take advantage of the science and the medicine that's afforded to everybody. So with that, Dr. Demese, I will turn it back over to you.
Thank you so much, Mr. Sneed, and great work at J&J. I want to return later in the conversation to how J&J is supporting Black communities and others, communities of color in this pandemic. I want to go back quickly to Dr. Jones. You were talking about sort of how you define racism. We have a attendee, Karen Jackson, saying, what about, breast cancer? And so I want to also ask you to sort of define racism for us from your perspective. And then given as a family physician epidemiologist, can you talk about some of the other, in the nature of this double pandemic? One can just turn on the news, right, and see hundreds of people, namely Black people, on the streets for justice with, George Floyd, facing one pandemic around racism as they are also protecting themselves from catching, COVID-19. These are harsh but real realities. So can you talk to us about some of the disproportionate health effects that Black people face and define racism for us and why it's important?
Okay, so I'm going to start with a one-sentence definition, then I'm just going to hit it a little deep, and then talk about how it's turning into the disproportionate impact in COVID-19. And so I define racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. So I'm going to go back and hit the high points in that sentence and then talk about how that turns into COVID-19 and how it turns into kidney failure and turns into all of these other things. So the first important thing about that definition is that I'm defining racism as a system. So I am very clear that racism is not an individual character flaw or a personal moral failing or even a psychiatric illness, as some people have suggested, although it does manifest itself in those ways. But in its essence, racism is a system of power. And it's a system of doing two things. It is a system of structuring opportunity and of assigning value. And the blatant devaluation of our lives and our humanity is manifest right now. Okay, so on what basis does this system structure opportunity and assign value? It's based on the social interpretation of how one looks, which is what we call race. So we should all be clear that race is not biology. You know, and race is not even culture, and race is not poverty. It's associated with different things in different ways, but race and the power that race has as a marker of health disparities is because it is the social interpretation of how one looks in a race-conscious society. It is the substrate on which racism has operated historically and operates day to day. What are the impacts of this system? I named 3. When we do think or talk about racism at all, we understand that it unfairly disadvantages some individuals and communities. But it shouldn't take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage. So that racism is also unfairly advantaging other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about in this country, because it makes some people, especially some people living as white, some white people, uncomfortable. And, you know, I talk to all kinds of people all the time about racism. And I used to say, if you feel uncomfortable when I say unearned white privilege, I'm not trying to make you feel uncomfortable. Shake it off. You know, stay with me. I'll tell you some more stories. But now what I say is, if you feel uncomfortable, you need to lean in, because for all of us, the edge of our comfort is our growing edge. And I think that we are seeing people lean in right now in these days. But there's a third impact of racism. Yes, there's the unfair disadvantage and the reciprocal unfair advantage, but racism is also sapping the strength of the whole society through the waste of human resources. I could give you lots of examples of that, but I will just say that it is not only that Black lives matter. Black lives are precious. Black lives are brilliant. Black lives are activists. Black lives are problem solvers and workers and all of this. And so when Black lives are sacrificed either through the chronic disinvestment in our communities, the poisoning of our air and our water, the inaction in the face of need, which is how racism, and especially structural racism, most often manifests, as well as in the police killings of unarmed Black and brown men and women, in the vigilante killings, all that racism is sapping the strength of the whole society through the waste of human resources. Very quickly, and I will cede the floor, with regard to COVID-19, it is not that Black people were more susceptible, or we didn't care, or we weren't trying to take care of ourselves, or it's just our fault we ate too much fried chicken and that's why we have the diabetes and all that. No. In December 2019, there was no human on this planet who had immunity to this virus. And if opportunity were equally distributed across the planet, or at least in this country, and if exposure to risk were evenly distributed across the world, or at least in this country, we would expect to have no way that you could slice and dice the population and find differences in infection rates or death rates from this virus. So what COVID-19 did was expose that opportunity is not equally distributed by race in this country. Exposure to risk is not equally distributed. And COVID-19 pulled that sheet off of the structural racism in our nation. And so there are 2 things that are happening. Black and brown and indigenous people are more likely to get infected because we're more exposed and less protected. More exposed on the frontline jobs, you know, without adequate protection, more infected because we're overrepresented, we know the disproportionate incarceration and the like. And once infected, so we're more exposed, less protected. And once infected, we're more likely to die because we're more burdened by chronic diseases with less access to health care. And that, again, is because of the disinvestment in our communities, where racial residential segregation turns into racial educational segregation, job segregation, all of that. So what we're seeing is because of racism. Thank you.
Thank you for that informative response. Actually, on that note, I want to talk to Dr. Allen and kind of raise this question in line of Ashaki Lloyd, who's sort of talking about, has a question for you around how do we strengthen our public health infrastructure to prepare us to better respond to the needs of the Black community. NACCHO is on the ground, and so I would like you to speak to what trends are county and city health officials looking for as indicators for safety and to limit the spread of the coronavirus? And is there anything specific that the Black community needs to be mindful of with respect to that question?
Thank you. I actually was started to type some answers to that in the chat, just given time. But it's an excellent question, because when you think about the role of disaster preparedness, and as we mentioned, health departments and everyone they've created plans. I for 15 years wrote plans at the local health department level to address how we can respond in an emergency. Granted, those emergency like Ebola seem small in comparison to what we're seeing now with this pandemic. The second component of that is the length of time, the sustainability of those plans. So oftentimes you hear, well, you need to target sensitive population or key populations who may have a disparate need. And how do you build up your plans to address this and ensure that the communities are part of those plans? Which brings me to the real key message to what we can do moving forward is not just focusing on development of plans, but integrating resilience and recovery. Because that's the biggest thing that we have to contend with from a sustainability model. I can have as much plans as possible. Yes, we can say we have an emergency kit, but what are we truly doing to help build the infrastructure that allows both economic sustainability, income reinvestment, ensuring of the access to care and the models that if you get hit by a major pandemic or disaster, that the community itself has a leg up to be able to respond and to be able to recover and build that resiliency to where the future, they would not be as heavily impacted as before. And that's really a much longer conversation than a simple sentence or two, because it does require us to take those strong looks at those institutional and those power structures that have really been feeded into the social determinants of health that have left people on the tail end of being able to be truly resilient. We are resilient as a people because when you look at the intense trauma over the course of generational divide, that we are still here standing, right? That still we rise. So that tells you that there's an innate, also a natural immunity that we've been developing to resilience, but we truly have to make those actionable items, both for education, access to care, and all of these intrinsic points that are going to be both from an internal construct, meaning we have to be part of the solution, as well as reconciling what are those external factors that are keeping us from being as resilient as we would like.
Thank you for that. And sort of on the line of sort of solutions around these problems, which, at the CBCF, our goal is to put a racial equity lens on these issues. And part of that means that you don't ignore the problem, right? We don't want, even though racism or racial disparities have defined long-term gaps across, health indicators and health outcomes, you can't just avoid the problem in order to solve it. And I think it's incumbent upon, and we're lucky to have, leaders like you all in these positions of power to speak to, like, diversity in clinical trials, as Mr. Sneed alluded to. I mean, it's not just for diversity's sake, right? I mean, as we talk even about educational opportunity on in colleges and universities across the country, we're not pushing diversity because it makes people feel better. I mean, this is about redistributive justice in order to provide equitable educational opportunity and outcomes. So in that vein, President Burton, I want to ask you, in your leadership at the American Kidney Fund, what are some ways that the health systems can improve to mitigate these disparities in relation to the Black community? And specifically, what are some ways at the American Kidney Fund that you all are actually working to improve upon and mitigate these health disparities?
Thank you so much. And I want to, great question. I want to follow up from the last discussion, because I want to thank the CBCF for really focusing on this at this time, because we see some things in the lens of COVID-19 that I think all of us on this panel and many people who are participating here see all along, but it shines a light, increases the visibility in the way that you almost have to see them. Let me give an example around kidney disease. The interesting thing that I find about kidney disease is that when it starts off as chronic kidney disease, and sometimes it takes years and years, and hopefully in most cases it won't reach kidney failure. But when it starts off, the incidence is not disproportionate to Black people. In other words, Black folks get chronic kidney disease in about the same rate as their share of the population. It's over the time that it develops that it gets worse. And so by the time you end up in kidney failure, we've got 13% of the population. We've got about a third of the people who are moving into kidney failure. There's something really wrong about that. When it comes to the American Kidney Fund and what we do, our largest program provides financial assistance to help people pay health insurance and a safety net program to help them with other expenses. Over half the people we are assisting are African Americans. We've got to do something about both of those things. We must have our healthcare institutions at the public health level to really focus on kidney disease prevention. As with all of these chronic diseases, we could change the subject to a different disease. The actions that are needed would be the same. We have to focus early on education, on prevention. We have to identify those folks who are at the greatest risk. There are some genetic issues here. African Americans, Hispanics are at a greater risk. But then we've got to deal with making sure that we identify those folks, that we give them care early on. Don't wait until they're in kidney failure and just pay for them to be on dialysis. Certainly, if you're in kidney failure, you need to have that. But we need to be making sure that we're working with people, that they are in chronic care programs, and that they've got intense follow-up around their diet, around their medications, around understanding their susceptibility to the disease early on. Not only is this the more humane thing to do, not only would it help to reduce the disparity, but we all know that taking care of anything on the front end is going to be less costly than waiting until you're on the back end of that. And so what the American Kidney Fund does, our whole effort is toward fighting kidney disease at all stages, on all fronts. So we're on education, we're on prevention, we're on making sure that African Americans and other minorities are aware of clinical trials, get involved in clinical trials so that the therapies that are developed are also appropriate for them. And then if they're on kidney failure, we want to continue the education to make sure that they get the best outcomes and continue to make sure that they get to see the myriad of specialists that they need to see to best manage their diseases.
Great, thank you for that. We have a lot of feedback from folks who are wanting to learn more about the American Kidney Fund. And so I want to make everyone aware that all of these conversations and the session itself is videotaped and will be made available online. So you'll be able to contact these folks. And finally, before we start to engage questions from our audience, I'd like to ask Mr. Sneed to sort of follow up on your comments around sort of J&J's work, in particular, the support for the Black community and where Johnson & Johnson has been doing in terms of its outreach to communities of color.
Great, thanks, Dr. DeMasi. Yeah, so let me emphasize a few areas that I think we're really pleased with. First of all, no single organization is going to be able to solve all these challenges. This is clearly a global public health crisis. But when it comes to the specific actions that we are taking communities and communities of color, I think there's three areas. The first is around just getting and strengthening the data and the insights. Representative Kelly mentioned early on the need to be able to break out the racial differences. And Johnson & Johnson was, if not the first, one of the first companies to sign on and vocal support of making sure that we can actually look at the data because that will give us more insights in terms of how we can go forward in terms of tackling the crisis. Second is making sure that we can elevate and amplify all the actions that take place within the local community medical systems. So what I mean by that is not only the education we need to do, but also partnering with organizations like the American Organization for Nursing Leadership. They're an organization that is deeply embedded in communities of color. These are the nurses and other healthcare professionals that are on the front line. And so using our resources as well as our insights to certainly help them with regard to making sure that they have all the resources that we need. At Johnson & Johnson, we have a Center for Health Worker Innovation where we look to understand the innovations that are taking place in communities of color and then sharing those best practices out so that we can multiply that impact around communities of color. We also use technology. We know that no matter where you are, people have a cell phone, they have the ability to get messaging. And so we're working with federally qualified health centers to deliver critical information to over 3 million Black and brown people across the US in text messages around critical health information, doing that both in English and in Spanish. And then the last thing I'll say, which I think again goes to this point of how do we actually get and continue to be embedded in the community, as we are taking our mobile health clinics and deploying them right into the heart of communities of color, where we can deliver additional messaging. We can help in the testing to understand if people are infected with COVID-19. And then let me just, in closing, circle back to what I said earlier about the diversity in clinical trials. This is so important for our community to make sure that we have a voice, that we are heard when companies like Johnson & Johnson are developing vaccines and frankly, other life-saving medicines. We need to be represented. We need to actually have people who look like us in the field actually developing the clinical trials. And so we are pouring resources and money into that area as well, so that when people have questions about what it's like to be in a clinical trial, they can hear from somebody who looks like them, who has their same experiences. So along all those areas, we feel like we've made a good start, but we also know it's not enough, and that this is something that can't be the flavor of the month, so to speak, but it's got to be a long-term, sustained commitment, and that's what myself and so many of my colleagues at Johnson & Johnson are committed to doing.
Great. That is really wonderful to hear. Thank you, Mr. Sneed, for that overview of Johnson & Johnson's work. I think it's really important that we also know sort of these programs on the ground and how we can become involved and really look at J&J as an example of what other organizations and folks can do in the public healthcare space. So I want to return to Dr. Jones. We have a number of people that are asking you to define racism again, according to your definition. So if you can do that, and then maybe give us some practical steps in terms of what our community can do right now, understanding the nature of racism and how it manifests itself in the healthcare space. What are some practical steps? But first, your definition.
So racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. I want to pick up on what Mr. Sneed just said, and really the discussion that's been evolving among all of us. So when we say, where do we go from here in the short term, medium term, long term? There are three things we need to do if we want to engage in what I'm recommending as a national campaign against racism. We need to name racism, say the whole word. So it's good to talk about implicit bias and disproportionalities and disparities and even race. But until we say the whole word racism, we're not doing our job, because if we don't say the word racism in the context of widespread denial, we're complicit with that denial. So we need to name racism. Then we need to identify the levers on which we can act. That's what you're just asking me now. And we identify that by asking the question, how is racism operating here? Looking at the elements of decision-making. So how is racism operating here is a legitimate question, because racism is not a cloud you can't get a hand on. It's a system with identifiable and addressable mechanisms in our structures, policies, practices, norms, and values, which are all different elements of decision-making. Structures are the who, what, when, and where of decision-making, especially who's at the table and who's not, and what's on the agenda and what's not. So that's what Mr. Sneed was just talking about in terms of clinical trials, but it has to be at all decision-making tables. And if structures are the who, what, when, and where of decision-making, then policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, and values are the why. You can take that question, how is racism operating here in my child's school? Or how is it operating here at my workplace? Or how is it operating here in police killings of black and brown, unarmed black and brown men and women? How is it operating here in the underrepresentation of people of color in clinical trials? How is it operating here in COVID-19? And every time I'm asked to speak, I just spend 10 minutes with that question: how is racism operating here? Looking at the who, what, when, where, how, and why of decision making. And I come up with 10 to 20 possible levers of intervention for whatever audience they're interested. So that's the second of the three tasks for this national campaign against racism. Name racism. Ask, how is racism operating here, looking at the elements of decision making. And finally, we need to organize and strategize to act. So while I'm working on the presence of civilian review boards to monitor and hopefully control police practice, for example, in a community, somebody else needs to be working on something else and we can't just work in our own little silos, because racism is such a fancy system. If we're all focused on one thing, it'll just reconfigure itself and go around and do something else. So we each need to take the tools from our toolbox, you know, at NACHO, National Association of County and City Health Officials, at the American Kidney Fund, at Johnson & Johnson, you know, in each of our places, at CBCF, we take the tools in our toolbox, we identify a target, but then we link with others so that we can organize and strategize to act, to dismantle this system and put in its place a system in which all people can know and develop to their full potentials. In a long-term strategy, here are my top three, very quickly, top three policy agenda items. Reparations for descendants of Africans enslaved in the US, abolition of prisons or decarceration, however you want to describe it, and then massive investment in Black communities and brown communities, providing resources massive investment to provide resources according to need, not only in housing and environment and all like that, but especially around families and children. And we will know when we have been successful when the phrase disadvantaged child will have no meaning, because there'll be no way that a child could be born into or find themselves in disadvantage.
Mm-hmm. Mm-hmm. Thank you. So Rich, you know, Dr. Allen, I want to turn it over to you, because as we talk about economic justice and some of the sort of pressing long-term issues that Dr. Jones outlined, how does an organization like NACHO take that into account with the work that you do? So again, back to this issue of how do we put a racial equity lens? And for the larger panel, I want to also, you know, I'm hearing a lot around, you know, the importance of data collection, right? And opposed to, you know, we are up against a lot. We're up against convincing people that these disparities are rooted in historic structural racism. That's one thing that we've got to continue to prove as we try to explain these disparities. The other is data itself. I mean, there is a high correlation between underreporting and the effects of structural racism, right? And being able to actually get those diverse clinical trials to be able to bridge this gap and address these disproportionate diseases. So things like economic justice, I mean, how does NACHO look at these particular communities of color that have these, you know, challenges that have been there for a while? If you could talk to that piece, that would be helpful.
Sure, thank you. And I smile because Kamara and I are both epidemiologists, and people always say epidemiologists like data. But what we actually say, we like data, but we like quality data. Data that actually gives us information that allows us to be actionable. The role of an epidemiologist is not just to do bean counting. We're actually aspire to a greater mission of taking the information and bringing that data to life to actually to ensure that we can enact change, develop policy strategies that can truly support and make our communities in which we serve healthier. So to your point around what are some of the methods or what are some of the things that organizations and entities can do, we from the National Association of County and City Health Officials have always been engaged with the role of how to ensure that community engagement is part of any type of governmental infrastructure or development of plans. You cannot create a health plan to improve a population if you don't have representation from that population, if you do not encourage to ensure that there is that connection and that it's not just lip service. So we've actually developed a Roots of Health and Equity course, which is a web-based course for the public health workforce that kind of targets health department staff and others to begin to investigate the relationship between social injustice and what are those fundamental causes of health inequities and how we can improve everyday health practice. And that's just one thing. There are several other tools that have been there to not only address the impact of racism. Several folks may or may not know of the Undoing Racism course, in addition to the natural causes, which has been, I think it was a PBS series, and these are just tools that try to illustrate the impact of inequity, of wealth disparity, of housing disparity, and how all of these stressors, et cetera, do have an impact on our lives. And I think we are at a juxtaposition now where the conversation that several folks have been having for decades now seem to be listened to. There's this spotlight, this attention being paid. And I'm hoping that this catalyzes us to be able to not just talk, but to really get the fundamental movers and shakers, those upstream elements, right? Both the community as well as those policymakers, those elected officials, and everyone who is in whatever shape or form, from private business to public business to whatever it may be, social services. You all have to make sure that we're not just talking, but that we're taking this moment in time that has shown us that the impact of, in the midst of a pandemic, in the midst of a global pandemic, that racism and injustice has actually superseded the mitigation efforts that we have been trying to control. Meaning we are trying to stop the spread of the disease, but this bigger disease has now came and said, guess what? I have the trophy, and we are now changing the attention span, which has even amplified our concern as far as how we can really address this other pandemic on top of the pandemic. So I would say that there are tools, there are publications, there's a plethora of materials that we can take, fashion, utilize from a community's perspective, utilize from a organization and institutional perspective, but it takes the drive and the commitment to see it through in order for us to really, truly start to impact substantial change and informative change.
Thank you for unpacking that. We have a question here from Dion Burkhalter, who says, how do we as a society demolish systemic racism? Where do we begin? I think it's important to highlight, that all things big and small that move the needle, an inch or a foot or a meter or a yard, it all matters, right? Having positions of power and leadership like all of you, having this conversation so people can understand how to make these linkages, it all matters. It's all necessary. And so I think and it's all correlated, right? I mean, if we didn't have voices like yourself in these positions at these influential places, we might be missing out on a significant portion of reaching the Black population. So I think as we talk about demystifying, the fallacies of racism and making Black people inferior, we also have to understand there is a blueprint for change. We would not be here if there wasn't, right? So we can talk about the disadvantages and the disparities, but we can also talk about how we have moved with the needle since then. Part of what racism does is tell us we have no history, we have no past. Professor Errol Henderson at Penn State says this all the time. We cannot be victims of racism mentally, right? We have to understand that things are moving, right? And you all are speaking to that. So I want to turn it to President Burton. I mean, what have you, and really let's open it up for everyone, but just given your leadership as president of the American Kidney Fund, what have you sort of experienced? What have you been able to acknowledge and sort of take advantage of in your role to really speak up about these issues for you, but also for everybody who works at the American Kidney Fund and your partners and the community? Can you just shed some light on sort of your story and your sort of personal efforts in your role at the AKF?
Thank you. I think one of the things that we early on realized is that we needed to get patients out talking about how all of these issues affect them. We started a patient advocacy network, and what we want to do is give patients a platform and help them find their voice to tell their story. People don't understand. You asked at the beginning, why kidney disease? Why are we part of this program? So many African Americans, as I mentioned earlier, are affected by kidney disease. And it affects them in so many different ways. A person who has that story can tell it a lot better than I can, sitting in front of a congressperson or a state legislature or in any venue. So we want to make sure, and that's why we spend a lot of time making sure that patients connect with public officials, that they connect with the media, that they're the ones who are telling the story. And we look for other partners, especially community partners. we've got a staff of about 100 people, which is fairly small for a charitable organization. But we are reaching virtually every person in this country who's on dialysis or who's had a transplant, and many millions more who are at risk for kidney disease. Part of our strategy is to develop materials and a voice and give those to others who can help us to get our story out, who can help to leverage the issues for the decisions that we need to have made. We have corporate partners, and I mentioned our Know Your Kidneys program that we started about a year ago to focus on people who are at risk so that people understand their risk. That's funded by Janssen, and we are very grateful for that financial support. So we're partnering with foundations, we're partnering with corporations. We are enabling individuals and organizations and various levels of government to work with us. And at the center of all of this is, let's find and enable the patient voice. It is the most powerful tool that any patient advocacy organization has. And we're just tremendously proud of our patient network. And we intend to make that more and more powerful, and to make that voice louder and louder.
Great, thank you. Anyone else on the panel, just in terms of sort of for those who are looking for more resources or to get engaged, what are your suggestions for first steps to get smart on these issues, whether from a Johnson & Johnson perspective, nature perspective, from a research perspective? Remarks, yeah, Mr. Sneed.
Yeah, first of all, I wanted to, and the work that Levarn does is terrific, and we're very happy to support that. But I wanted to swing back to what Dr. Jones said on a couple of points, and it does go to this issue of structural racism. Over the last several weeks, we've had multiple conversations across Johnson & Johnson, having really raw and candid conversations around what as a company, and look, companies are nothing more than just individuals, right? Groups of individuals. And we happen to have 135,000 J&J colleagues. But we've been having really good conversations about what it's like to work at a company like J&J, but for our Black and Brown colleagues, what it's like to be in society and the additional burdens that we have. And those conversations have been led by our CEO, Alex Gorski, and myself and others. And I would say there's been a few things. One is that it's incumbent upon white people to educate themselves about what racism is. That can't be a burden left to only Black people. That's a burden, frankly, that's just too hard. Secondly, you have to understand that it's not enough to be on the sidelines anymore. We had a very, very powerful conversations about this idea of being visibly anti-racist. And that's about taking those actions, both small steps and big steps. So it's small steps in terms of never letting a slight go by or an inappropriate comment, but also bigger steps in terms of how we are looking at promotions and development opportunities for people of color across Johnson & Johnson. And then when it comes to the community, I think it is important that myself, other people in the community, physically advocate for better healthcare for our communities. This is where the CBC comes in and others, but it is about that long-term investment in our communities, because not only does that help us as communities, but it helps the rest of the country. And I think that's incredibly important. And then finally, what I would say is, because we're a healthcare company, we tend to look at it through a healthcare lens. And I would say I heard a great way to characterize what this is right now. And what they said was a young Black man who works in our organization. And he said, Michael, we've got COVID-19 that we're dealing with, and we will get an answer to that. But we also have this virus of racism, and I like to call it COVID 401. And that's for the 401 years that we have been dealing with this issue. And it's going to require that mindset the same way we are tackling this other virus. We have to tackle it with the same intensity and the same long-term commitment to finally undo the structural racism that exists in this country.
Thank you. COVID 401. All right, Dr. Jones, go ahead.
So thank you. That's
Powerful.
all of this. I'm so happy that from all of our angles, we're like boom, 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 boom.
Yes.
So I want to take us back to the image. So I didn't share slides, but the image of this open close sign, this dual reality, some people sitting in the restaurant at the table of opportunity and other people outside unable to get in. And I want to propose some actions using that image. So the first action has to do, it's to actively look for evidence of two-sided signs. That is, so that's the data piece that we've been talking about. That is asking the question, is there something differential going on here by race, by zip code, by language, by immigration status, whatever. So that's the data piece that we sort of picked up. Actively looking for evidence of two-sided signs as opposed to sitting back and saying, oh, the sign says open to me, you know, so this must be a land of equal opportunity. The second is acknowledging that we all travel in bubbles of our own experience, our children, our communities, our jobs, you know, all of that. Some of our bubbles are big and expansive with thin soap bubble boundaries. Some of our bubbles are very small with thick plexiglass boundaries. And sometimes we're tinting those and we're polarizing them and we can't see out. But whatever the size is of your bubble, we all recognize that in our bubbles, we often do not know that just across town, there are people who are just as kind, funny, generous, hardworking, smart as we are, who are living in very different circumstances. So it is incumbent upon us as individuals to burst through our bubbles, to experience our common humanity in different circumstances and do that connection. That's being done in the streets right now of cities across this country and across the world. But it's also a challenge to companies and institutions to create bubble bursting opportunities. So I put that out there as a thing to do. The third thing would be to be interested in the stories of others, to believe the stories of others, and then to join in the stories of others. That also is happening in our streets right now in response to the murder of George Floyd and Breonna Taylor and you know, Ahmaud Arbery and, you know, baby Tamir Rice and like all the back, you know, I can give you a litany on the top of 40, but that's just the ones who have come to national attention. So, and all of these things I'm actually saying are ways that people who are born inside the restaurant can know something about the two-sided nature of that sign, right? So, you can't say, oh, well, there was no way for me to know, many ways to know. The next thing we need to do is develop a sensitivity to seeing the absence of. That's a special way of understanding and seeing. So when we're sitting at a decision-making table, our first job should be to look around and say, who is not here, who has an interest in this proceeding? And then our job is not just to represent their interests, although that's an important thing to do, but our job is to create space at the decision-making table, to find them a way to the table. So to see the absence of who's not here, what's not on the agenda, what policies are not in place that if put in place could be much better. Then the next thing we need to do is to identify inaction, to reveal, if you will, inaction in the face of need. Because that is the main way that racism operates these days. You know, the most profound impacts of racism happen without bias. Because we have set up structures historically, and then we have present-day contemporary structures that are perpetuating things, and there is no need for an identifiable perpetrator. It is on autopilot. But then all of those actions have been from the perspective of those inside the room. So I just want to say, for those who are outside, we need to know our power. We need to recognize that action is power, and we need to especially recognize that collective action is power.
Amen. Amen to that. Dr. Allen, go ahead. As we'll be wrapping up in about 10 minutes, but please chime in.
Thank you. I was trying to get him before Dr. Jones because you can't follow Dr. Jones. I wanted to say an excellent point that everyone has raised, but an additional point that I wanted to really underscore, especially as we talk about the issues, the implications, and the next steps as it pertains to racism and the impact it has on our community. Our community has shown time and time again that it is not monolithic. Mm-hmm. The desire, the need to have these conversations are very strong. The emotions are raw. The images that we see on a daily basis have really changed the tide. But there's another portion of that conversation that internally to the African American diaspora that we also need to really adjust and have. Because if we cannot be true to ourselves, we cannot necessarily have a very strong success rate in dismantling the systemic impacts externally. And within ourselves, we know that there's differences between our diaspora, between the way we interact with within ourselves, within other groups, other minority entities, other minority populations. And it is imperative for us to recognize this, as Dr. Kamara just basically mentioned, this is a comprehensive approach. It's going to take time, it's going to take effort. Yes, we want to knock down the blocks of things that are really been in your face for hundreds and centuries, for hundreds of years and centuries. But there's that other, because we're not monolithic, we know that not one set of actions are going to be the answer for everyone. And everyone is in a different stage of either maturation or of self-consciousness or having the ability to even emote the emotion, the trauma, remember the trauma and the mental health and all these particular impacts that has been compounding our station in life, whatever that station may be. So I just wanted to point to that internal conversation is going to be as much as an important factor as what we're seeing from the external realms if we are going to be successful.
Yeah, no, amen to that too, Dr. Allen. I think there's so much to take away from all of your remarks and comments. And I really hope as we look forward and we're getting a feedback on sort of appreciation from our attendees for this comprehensive conversation around public health and battling COVID, because it's so interrelated, and explaining these disproportionate effects are key. My last question before I ask each of you to sort of give us your 1 minute closing remarks are around this piece about data. So I often talk about the fact that in a post-civil rights era where discrimination is illegal, but yet we know it still happens, it is much harder to identify covert forms of racism, right, that explain these differences. However, data continues to show us with pretty significant probability and significance that these disparities are based on these structural institutions that, quite frankly, we're all playing a role in if they're not reformed, right? And to some of the points Dr. Jones and Dr. Allen you've made. And so, when we talk about whether it's the diversity in clinical trials or it's turnout for the census that determines the allocations of billions of dollars to say, this is how many of us actually live in the United States, right? And deserve a fair share at America's pot of resources. When we look at socioeconomic indicators like the wealth gap, the unemployment gap, the poverty gap, and we continue to see race explain with significance all of these differences, it's very difficult for me to wrap my head around these arguments that race doesn't matter, and not just race, but racism as well. And so my question is, what can we do like J&J, but also if we're not in the healthcare space, but we're in another space, whether it's housing or education, how do we make sure that data accurately reflects and continues to reflect? Because the reality is there's a lot of state legislators that are also turning things around. They don't want data based on race because it tells us things we don't want to see, and then it requires us to do more of this work. So I just want to, turn that over. What is the power of data in 21st century in combating racial discrimination across the board, but in particular with regard to this double pandemic we're talking about in a COVID climate?
I know the EPIs are like frothing to respond.
Was that directed to Mr. Sneedy?
Yes, that's what I wondering who was it directed to?
Oh, all of you, anybody, just to talk.
Oh, okay.
Talk about the power of data, and we can do that while you close your remarks. If I could have each of you sort of respond, that would be great.
Well, I don't want to go first because I have 3 things I want to say, so I'm going to let everybody else talk about it.
Dr. Bessie, I can talk about that and then close.
Please.
At least my part. So obviously, it's no surprise that at J&J we thrive on data, and so we believe that the more data we have, it actually allows us to be stronger advocates for people of color. And we can use our voice, and we do use our voice down in Washington and in state capitals, because we know that because we are a large company, we can use our big for good in getting the attention of the people who are making these decisions. So I think that is what we've tried to do and will continue to do. And then as it relates to just the overall approach to this pandemic and the double pandemic, I just want to broaden it out a bit and speak to the fact that at the end of the day, we have been big supporters of universal health care. And that is really a big lever in terms of getting and keeping our communities in good, not only health shape, but in good financial shape. When you don't have to worry as much about some sort of catastrophic event, causing you to go into bankruptcy or to lose your home, or you can have access to doctors who you know and the right medicine. So I do think that beyond this particular pandemic, this long-term notion of making sure that every citizen can have access to universal health care is going to be critical for ensuring that we can continue to have and grow our communities, be as healthy and as financially stable as possible.
Thank you so much. President Burton, let's go.
Thank you very much. We are a data-driven organization, which is maybe a little bit unusual for a charitable organization, but we try as best we can to count everything that we do, to count our impact, because that is much more powerful in not only describing to others who would support us what we're able to accomplish, but it helps us to understand where we need to go next. I think that this is a moment in time, and we all, in our various areas, whether it's housing or health or wherever it is, we need to take advantage of this moment in time. We need to share the data, share the facts, and we should not be shy about doing that. And we shouldn't be back off because someone challenges us. Then we should respond to the challenge. We've talked about clinical trials, but there's an aspect of research that I think have not addressed, and that is what's the focus of the research. We need to make sure that as we try to understand COVID and many other issues as well, but COVID is the subject of the day, we need to look specifically at how it has impacted African Americans, how it has impacted the groups which we're most concerned. We can't just look to general research to understand the facts. We've got to follow that data in terms of its impact and make sure that the research addresses those issues, because that's the only way that we can move forward and improve the care that we're giving to folks.
Thank you. Dr. Allen?
Thank you. Okay, thank you. It's always bad to ask an epidemiologist about data, right? Data for us, and there's power behind data. To your point, if you don't collect it, if you don't understand it, therefore you are not empowered to be able to address and make those points and those recommendations, those strategies, those interventions to really come out from a sense of value and purpose. So for our lens, the way I look at it has always been kind of one of the biggest issues that I've had to be as an epidemiologist at a local level, how to ensure that the data that I have at my fingertips is timely, is complete, and is accessible at a grassroots level. It's easy oftentimes to collect data at a national level, and it says, well, the US is this, but then you look at each individual states. Well, the states say this. And then they say the county is that. But as we have always seen, the more granular your information, your data points are, the better you're able to make decisions. So historically, when I've been able to address the impact of access to early prenatal care in my county when I was an epidemiologist, my total county had a very affluent population of women who got access to care. But there were pockets who did not, 5 times below the average of where they needed to be. So the data, unless I was able to get it from a granular perspective by going in and physically collecting it, was not going to be helpful at this larger, ceiling level. So the granularity of the data, the ownership of the data is going to be important. The other flip side to this question that I always smirk at is that I even tell my mom that, with respect to COVID, everyone all of a sudden became an epidemiologist. You had all these folks that are on social media and like telling you, well, this is the RT and this is the, and the fatality rate. And I'm like, I didn't remember any of these folks in school when I was there. But the reality is that has really pointed to an interest in our community, as to your point of your question, across all facets of the industry.
Right.
And that's where it's important for us to really have a better understanding of when you're talking about data, no matter what your industry is, that there's a set core of standards and an outcome that you're looking to derive to be really successful if we're going to take that power of the data and formulate it into action.
Great. Before we close with Dr. Jones, I'm going to take 2 minutes after her comments to share with you updates for our next week and ask you all to take a quick survey on today's session. So as we move into our annual legislative conference, we encourage all of you to join for our virtual conference so we can continue these discussions and the good work that we're doing. So briefly, Dr. Jones.
Very briefly, on data, data are important. That is how you answer the question, is there a two-sided sign operating here? And we need to look not only at outcomes, but at opportunities and exposures. I saw a question about, what about gender, sexism also exists. Yes, my definition of racism can be generalized to be a definition of any system of structured inequity. What is sexism? A system of structuring opportunity and assigning value based on gender that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. On achieving health equity, 3 principles. If we're going to achieve health equity, we need to value all individuals and populations equally. We need to recognize and rectify historical injustices, and we need to provide resources according to need. And then very quickly in a list, 7 barriers that we need to address in this nation, the values underlying our nation, if we're also going to dismantle racism. 1, the narrow focus on the individual, which makes systems and structures invisible or irrelevant. 2, the fact that we are ahistorical as a nation. We act as if the present were disconnected from the past and as if the current distribution of advantage and disadvantage were just a happenstance. 3, our endorsement of the myth of meritocracy, that if you work hard, you'll make it. I give you that most people have made it work hard, but there are many, many other people working just as hard or harder who will never make it because of an uneven playing field. 4, our endorsement of the myth of a zero-sum game. If you gain something, I lose, which masks the cost of inequity. 5th, our limited future orientation. We can touch the future in our children and in the planet today. That's how we can touch the future today, and we don't invest in our children, and we have a usurious relationship with the planet. 6, our endorsement of the myth of American exceptionalism, which makes us think that there's nothing we can learn from other countries. And 7, white supremacist ideology, the myth that there is a hierarchy of human valuation, the further myth that white people are at the top. That gives white people a sense of entitlement. It causes dehumanization of people of color, and it has caused this fear at the browning of America, which is the basis of our current political situation right now. Thank you.
Amen, amen, amen. You let us know the next time you are going to be preaching, because I will be right there. Thank you, thank you, thank you, Dr. Jones. To our distinguished panelists, Dr. Allen, President of American Kidney Fund, Levarn, Burton, and of course, Mr. Sneed with Johnson & Johnson, who sponsored this important conversation, our 5th virtual brain trust. We are so thankful. I'd like to ask my team to put up the slide for our next and final virtual brain trust, as well as our survey. Before you all take off, if you could please let us know what you think. We want to continue these important conversations that result in policies and community initiatives and results-driven results and solutions for our community. So please let us know, your thoughts on today's conversation. I want to also, again, alert you all to our 6th Brain Trust happening on June 18th at 3 p.m. Eastern Standard Time. We'll talk about water justice in a global pandemic. We're really excited to have Senator Kamala Harris, no stranger to any of us, but she happens to actually be a very, very strong leader when it comes to water access, equity, and opportunity. So please join us, as well as being able to listen to our very own Dr. Afia Zakia at the Congressional Black Caucus Foundation. Our Water Infrastructure and Workforce Development Senior Fellow will join us for a second conversation on water. Again, I want to thank our distinguished panelists for today's excellent, excellent discussion. And a special thanks to Johnson & Johnson and Michael Sneed for the work you do and for being a longtime supporter of ours. For more information, please join us at www.cbcfinc.org. Policy for the People. You can learn about all of our sessions, which are videotaped and available for you to revisit all of our conversations and learn more about how to engage with us. Again, that's www.cbcfinc.org. It's been a pleasure being your host and moderator for today, and thank you all for joining. Until next time, take care and stay safe and healthy.
Thank you.